And you're live.
Hey, good afternoon, everyone. Thank you for attending today's talk. Let me introduce our speaker, Dr. Elizabeth Davenport. Dr. Davenport is Assistant Professor of Radiology and serves as a Technical Director for MEG Center for Excellence at UT Southwestern Medical Center. She earned her PhD in Biomedical Engineering from Virginia Tech Wake Forest University and completed postdoctoral training in clinical MEG at UT Southwestern Medical Center. Her research focuses on investigating the ability of advanced MRI and MEG metrics to serve as biomarkers for concussion in adolescents and biomarkers that can assess risk for dementia early in the disease process. Please join me in welcoming Dr. Elizabeth Davenport.
So much for the intro. All right. And you guys can see and hear me or at least see the slides? Okay, cool. Awesome. And I'm getting over a migraine for this morning, so bear with me a little bit. Oh, I know. Whoever's doing migraine research, you're my favorite person this week. I'm going to tell you guys a little bit about the research that we've been doing over the past couple of years and then some of the newer stuff that we're getting into more recently. So first of all, disclosure, I do some consulting for the MEG manufacturer, but actually I use a different machine in the research, so I think it cancels out. So first of all, let's just do some basic definitions. So TBI, or traumatic brain injury, I think we've all heard of it before. There's severe, and then there's moderate, and then there's mild, which is also known as concussion. So the more severe means loss of consciousness, you're in the ICU, you have a brain bleed. Moderate, again, you're going to have maybe some imaging findings there, but the more mild stuff, actually part of the definition of a mild TBI or concussion is that it's negative on traditional imaging. You're not going to really see it on traditional clinical imaging. And the diagnosis is purely based on symptoms reported in neuropsych testing. So again, that standard clinical imaging is normal. Loss of consciousness is not required for a clinical diagnosis of concussion. I always like to point that out. And it relies on those symptoms. You don't have to physically hit your head to get a concussion. You can have that whiplash effect. And there can also come from blast injury, those blast waves traveling through the body. So just to outline all of that. So brain injury has been talked about in football since 1928, when it was first described in JAMA as punch drunk. And so this is, and we've been doing some really advanced helmet testing since the 1920s, just kind of seeing how things go. And so this is, we've known for a long time, it's pretty obvious, like hitting your head is bad. This is not something you want to do routinely. But we're still here, we're still researching this. And so just to kind of give you a timeline, 1928, we described punch drunk. It was actually in boxers, not in football players. And then in 1994, so it took us, a couple decades, the NFL created an MTBI committee. That's their primary job was essentially to deny the presence of brain injury. In 1999, Mike Webster claims that football gave him dementia. And so he was a center for the Steelers, and he was homeless. He was really struggling a lot. He was having a lot of behavioral issues. And in 2002, when he passed away, Bennett Amelue performed his autopsy and found these tau deposits in there. And so Dr. Amelue took around this pathology without telling anybody who this was and said, "What do you think this is?" And everybody was like, "Oh, Alzheimer's." But it was a different spatial pattern, and it was a little bit weird. And so he held on to that for a little while. Kevin Guskiewicz, who's at UNC now, had a paper that suggested repeated concussions may lead to slower recovery of neurological functioning. Again, it's kind of this more basic stuff that we now are very aware of. And then in 2003, that the NFL MTBI committees just started publishing all of this stuff in peer-reviewed scientific journals saying concussion isn't real, essentially. Like they were going through and but they acknowledged that concussion and brain injury exist in boxers and these other sports, but not in the NFL. No, never. And so then in 2005, Dr. Amelou finally published those results of Mike Webster's autopsy, calling it CTE. And so the drama was real. And especially if you were in this field at this time, the NFL committee was like calling for retractions. They were doing press conferences. They were kind of coming after these scientists that were saying, no, this is a real problem. And then Anne McKee is a researcher at BU, I believe, who first published another paper on CTE in athletes, so kind of backing up Dr. Amelou's work. And then finally in 2011, so decades of all of this, they finally did the first thing to move the kickoff line and to reduce head impacts and concussion. So just kind of this background of what we've been through over the years of looking at is even admitting that concussion is a problem in contact sports, specifically the NFL. And then when I was in graduate school, we saw a lot of changing times around safety and concussion. So we actually started doing these Virginia Tech helmet ratings where we would take the helmets and you put them on a hybrid 3 crash test dummy that they used for car crashes and look at how much acceleration these different helmets are mitigating. And this advertisement down here in the bottom right is actually the Schutt helmet when they won the most acceleration mitigated. I think this advertisement came out in 2015. This was a social media post, and they were proud of it, which was one of the first things that we ever saw kind of moving towards that safety of the game. And then we also saw heads up football, where they're changing the way that they're teaching kids to tackle, where they're starting to change. So we're finally like recognizing this is a problem. We're going to start researching it. We're going to start looking into it a little bit more. And then in 2015, Will Smith got to play, but Dr. Bennett Amelou, I say that Will Smith was allowed the pleasure of playing this great scientist, not the other way around. But and so we really start to see this coming into more of the social media, into the attention of the general public. And then in 2017, there was this New York Times article that came out of Dr. Anne McKee's work, where 110 out of 111 of the NFL brains that were donated to their brain bank were seen to have symptoms of CTE or have that tau pathology deposited. Now, I will say there is a sampling bias here, because the people that are donating their brains to the brain bank are the ones that are going to have symptoms, that are going to have concerns, and are probably going to bias themselves towards that positive result. But it's still really shocking. 110 out of 111 that were donated have this pathology. But let's talk about this a little bit more and go even a further step back. So 23,000 men have played pro football. It's probably 24,000 now since I've made this slide, but 6,000 roughly have died. 111 were included in the study. So it's a very small sample. Okay. We also still have a lot of players still living. Contact sports, collision sports like football are fairly new. And so we still have a lot of these players still living. 2,000 are currently playing and 250 are being drafted each year. So the studies that are going on these autopsy studies especially are a smaller sample. So we need to have a way to look at this in the living population, especially in those that are being drafted, that are starting to just expose themselves to this. So with that, I want to point out that those that are currently playing in the NFL league, where the attention is there's 2,000 in the pro leagues. Then to play in the pro leagues, you have to play in college to get drafted, right? And then to play in college, you probably played in high school. And to play in high school, you maybe or most likely played at the youth league. Well, the youth league is the real base of this iceberg, where you have 3.5 to 4 million kids playing in unregulated leagues. So these are run by parents. They have no medical oversight like the NFL, where in the NFL level, this is from last year's when the player had the cardiac event on the field. they have 4 athletic trainers, they have a dentist on the sideline. They have all of this support. They have all of this stuff going on at the NFL level and even at the college level. So at this youth level, though, where their brains are still developing and really where they're learning the sport, totally unregulated. So why not just, so I always like to pause here and say, because I get the comment a lot, well, just don't. Yes and no. It is a good sport. Cardiovascular health is very important. They get a lot of benefits from playing sports. And so people, especially kids, get concussions just as part of everyday life. So even if you're just out riding your bike, wearing your helmet, this is still an important thing to study. Car crashes, things like that. Contact sports athletes are at a much higher risk, which makes them a really nice population for us to study, because if I want to spend money on getting a baseline scan before somebody gets a concussion, instead of doing 1,000 kids just in the general population and taking my chances on maybe one of them getting a concussion, I can do a lot of kids playing a collision or a contact sport, and they have a higher chance of getting a concussion, a better chance of us being able to study and help. And so, and lastly, I'll say that the military personnel are often also exposed to these subconcussive and concussive impacts, which is another important population for us. So, okay, so we need prospective studies. We need to start studying it at this youth level. But how do we do that? Because we've gone from an unremarkable CT, completely total clinical imaging, to tau accumulation and this terrible, debilitating neurodegenerative disorder. So we're in the dark, somewhere in between here. How do we do this? And I do want to say, when I do this slide, that concussion and CTE are related, but this relationship isn't well understood. Having a concussion does not mean you're going to develop CTE. We're still trying to understand that relationship. So right now, the diagnosis of concussion, again, is symptom-based. So there's no quantitative metric. If you have a headache, all this kind of stuff, ringing in the ears, and then they're told that as you're recovering, if it hurts, stop, take a break, take a rest, and then go back to it. That's really like, there are some other interventions and things like that out there for the concussion, but on a whole, there's not a lot of treatments or a lot of prognosis for this. Then if you have those concussion symptoms for longer than months, you get what's termed post-concussive syndrome, which can be long-lasting migraines. It can be changes in your sleep. And so they look into these, the physicians often will look into these different domains and treat the symptoms, because that's all we really have is, okay, if you're having trouble sleeping, we're going to try some better sleep hygiene or maybe some medication to treat that symptom. If you're having vestibular symptoms, we're going to target these symptoms, not necessarily the cause, because we don't understand it well enough. And what about longer? What about people like Mike Webster, these other people that are ultimately diagnosed with the neurodegenerative disorder? So again, we're just in this dark, this whole period where you've gone from negative clinical imaging to the autopsy. So from animal studies, we've had some insight on this. We know that the biomechanical forces initiate this ionic flux and result in this extensive and indiscriminate release of neurotransmitters. It's essentially a sponge. You squish it together and everything just comes out. It goes, all the neurotransmitters are going crazy and they're going everywhere. So you see some neuronal suppression, you see impaired metabolism and neurotransmission, and then in this invasive animal models, we've been able to, I say we, Dr. Giza has been able, other groups have been able to map those neurometabolic cascades, and we don't really see a true return to normal until about 10 days after. Now, we do know that there are functional changes as well. So these neurometabolic changes correlate with a specific rhythm of an active neural population. So, for example, the spontaneous or resting state is often in the alpha range. So this is often measured with EEG, and EEG we know from, say, severe TBI, those in the ICU, you're going to see focal delta slowing, you're going to see a shift in those brain patterns. One thing that has been suggested fairly recently is that This slowing actually might be a healing mechanism, metabolic cleaning associated with the slow wave, which I think is really interesting. I don't know that it's fully understood yet, but the point of that is that this functional changes are giving us some insight into what's going on at the neurometabolic. And so the way that our group has actually chosen to measure this is using MEG, or magnetoencephalography. This is a non-invasive technique measuring the postsynaptic potentials within a millisecond time scale. So this is our director's youngest kid modeling it for us. He's very lovely. And so he's wearing a 64-channel EEG cap that can be acquired concurrently with the MEG. He's not all the way in the machine because artistic direction, but and so the sensors kind of fit around the head like this. They're those blue squares, and they pick up the neurons aligned perpendicularly with the cortex. And then right-hand rule of physics, anytime you have an electrical signal, you have a magnetic field that wraps around it. And so in this case, we're going to see those postsynaptic potentials, a bunch of them all fire together in that electrochemical gradient. And we're going to get a magnetic field that loops around it. And that's on the 10 to the negative 15th Tesla. So femtotesla range. So really, really tiny magnetic fields. But what it does, there we go. So we're going to come in, we're going to go into the shielded rooms because of those tiny magnetic fields. We want to block everything else out. We only want to listen to the one thing. And then they come across a lot like an EEG signal. They're just squiggles at this point. And so what's really great, though, is that those magnetic fields are unperturbed by the different density and tissue structures in the brain. So whereas EEG, you have to think about the different conductivity of the different tissues to model it back into the brain. For MEG, it just goes really nice and cleanly back into the brain. And so it looks something like this. So we're able to model it on the millisecond time scale at about a 4x4 millimeter voxel resolution to map that activity back to the brain. So we, of course, were not the first ones to show this, but back in 1999, there was a group, I think at Pitt, that showed that MEG is really sensitive to post-concussion symptoms in even more so than MRI or EEG or even SPECT. So they actually localized the slow waves that we were talking about that you see in more severe TBI, but in concussion, they were actually able to localize them to the temporal lobe of these patients that had persistent post-concussive disorder. Now, moving to kind of a more modern approach, the little bit better images here. These, so this group at UCSD they have this method called FAST-FESTAL, where they compare the delta power to a normative database. And this is in adults, so they're doing military personnel primarily. It highlights areas with abnormal increased delta power, and it's 85% sensitive to mild TBI and 100% sensitive to moderate TBI. But what's really interesting is that the areas of that are related to their symptoms are what light up. So we see the delta in terms of this participant here with the personality change. We see that delta appear in the frontal lobe. And so we said, okay, we're going to use this. We're going to use this tool and we're going to study kids with it. So we started the imaging, telemetry, and kinematic modeling study, and this was at Wake Forest back in 2011. And so pre-season, oh, this is displaying a little weird, sorry about that. So pre-season, we did cognitive testing, MEG and MRI on high school and youth football players. We have about 300 players total over the couple of years that we did this. So pre-season, we did all of this testing. We had them wear helmet embedded sensors throughout the season so that we can know how hard and how fast and how many times they hit their head. And so we were on the sidelines for all of that, which I know a lot more about youth football than I ever thought I ever wanted to know from sitting on the sidelines collecting this data. And then postseason, even if they didn't get a concussion, we collected that data again. And then we also had this data for a non-contact sport control group. We did swimmers, tennis players. We tried our best to get BMI matched, but if you're in the South and you're trying to get a BMI matched kid to a football player that isn't also playing another contact sport, it's a little hard because they put those, if they look like they should be a football player, they have to put them into football. So kind of in general, preseason, we have all of these measures. We measure their head impact exposure throughout the season and then postseason. Then we also have a concussion protocol. So as part of our study, as part of the NIH funding, we had a certified athletic trainer that was on the sidelines because the youth teams did not have it. They had no medical personnel on the sidelines. So we paid for one to educate the parents, educate the coaches, and be on the sidelines for every practice and game so that we could capture those concussions as soon as we knew that they were coming through. So concussion was suspected. She assesses them on the side of the field. The study team was alerted. We made an appointment with the sports medicine physician. If the diagnosis was confirmed, we scheduled their post-concussion appointment and we did their imaging, all within 72 hours. So we were on the phone all throughout the fall football season, trying to get these kids in. And so I say that because we were only able to get about 8 kids with a concussion, and I don't have that number on here, sorry about that. So we have 8 concussed football players, 8 football players that were BMI and age matched that I just pulled randomly from the rest of the study. And then we had 8 controls that, again, their BMI is a little bit lower than the football players just because it was so hard to get that BMI match. So we have 8 minutes of eyes open resting state data on a CTF machine at Wake Forest. It's a brand of Meg. And then we process them in Brainstorm. So for those of you that do EEG, very similar processing. We filtered it to the 1 to 100. We did ICA to remove kind of those eye blink artifacts, co-registered it with their T1 MRI so that we could localize it and then source localize that data. And what's really shocking or what's really impressive about this to me is that this looks like something I could push to PACS for the radiologist to read tomorrow. Now, what you're going to do with that information, that's a whole nother discussion, but preseason, this participant had some lingering delta waves. We're not really sure why. And then post-concussion, though, you really see those delta waves in that posterior kind of parietal region. And that matches with where they had their head impact. So this, and it almost seems to have a coup contra coup type relationship with that delta power on both sides. So here, you know, an increase over here, less over here. And then postseason, we still see some residual delta waves as well. And then this is just another example, prettier picture with 3D. So this 15-year-old middle linebacker, he was an open field tackling drill, helmet to helmet collision. So hitting the top of that frontal area. And then we see the delta waves primarily in the inferior frontal lobe, which makes sense kind of from a biomechanics perspective if you're hitting the front of your head and kind of pushing that brain into the skull there. So this is compared to their preseason scan. So this is the red here showing statistically significantly increased delta at that post-concussion scan. And then just on a very basic stats level, if we just say, okay, whole brain delta, what are we looking at? The control players, you see actually a slightly increase in delta from pre to post season. The concussion, you see that slightly increased delta. And then the football, it's primarily just stays pretty standard. And so one thing I will say is that delta power in this age group, we would expect to either stay the same or decrease with typical development. And one of the confusing things, though, is that when we look at this, when I look at the different players, so each of these lines is a different player. So we look at their concussion and then I look at their postseason. And I would expect that all of them would be healing and reducing their delta power, but that's not what happened. So we saw some, like our little gray guy over here, like increase their delta power, even though their symptoms decreased. This blue guy is like, you know, their delta power is decreasing significantly, but his symptoms actually stayed the same. So we're still a little bit confused on what exactly is happening here in terms of the clinical meaning of this tool. Okay. So another group, this is at UCSD again, was able to look at it and say, okay, if we consider the delta as well as also the gamma band, so the highest and the lowest bands. And so they saw the increased delta in theta, like we saw, but then they also saw I think it was a decrease in the gamma. missing a slide here, screwed all that, guys. Okay, so one of the things that we're looking at is we're recruiting right now, and we're scanning these participants right after their concussion within 72 hours. And then we're scanning them again in 3 weeks and then again at 3 months, so that I can further expand this graph and see what's happening here. And in addition to the MEG and the MRI that we're getting, we're also getting blood biomarkers and high density EEG, because maybe we don't need the whole MEG scanner. Maybe we can do it with a simpler metric like a blood biomarker. And so I'll touch on as well the repetitive head impacts from this study. So high school football players receive 400 to 2,000 head impacts per season. The type of head impact, the subconcussive impact is a type of head impact that doesn't cause clinical symptoms. A lot of times the reviewers will argue with us and say, well, subconcussive is a misnomer. I agree. It's a hard one. What do you call it? But they're hitting their head. They're not having clinical symptoms, but there's still something probably going on there. There's limited literature with the imaging biomarkers, but we do know that there's been numerous DTI studies, diffuse and tensor imaging studies with changes in FA. fMRI studies have shown changes in altered conductivity. And we know there's this very interesting study that did a retrospective analysis of those players who had CTE, the retired NFL players. And they looked back and they said that it was actually the repetitive head impact intensity and exposure, not the number of concussions or the severity of the concussions they had during their lifetime, that was correlated with their CTE severity. So it was that repetitive head impacts, not necessarily the concussion, the clinical diagnosis themselves. So we measured the head impact acceleration using helmet embedded sensors. These measure linear and rotational acceleration. If you want to get into the biomechanics, we can. It's kind of fun. But we are out there every day collecting this data. And we also have video to confirm that it was a head impact and not them throwing their helmet down, something like that. So, it'll play. Might not play. Oh gosh, sorry guys. Okay, I'll describe it to you. The 20 to 30 G impact is just kind of like almost like a bump. These kids get bumped, they fall down, they get right back up, they keep playing. It's just something you see every day in soccer, any kind of sport. So we also see though these 50 G impacts that are these higher impacts where this drill that they're playing in this video that's good. Is actually outlawed now. I think it's the Oklahoma drill where they literally just run at each other full speed and just practice tackling. And then the coaches make sure that they help each other up, which is good. So we're learning some manners or something there. But when you see these higher head impacts, people are almost always like, oof, oof, but they're still going. They're doing this routine. They go through this, they run at each other, and then they do it again, and they do it again, and they do it again. And so that just kind of logistically, when you think about that, what is happening to the brain. So that's what the study is about. So we quantified their head impacts using risk-weighted exposure. And so what that does is it takes a 20 to 30 G impact and gives it a decimal value and says, okay, that was a certain risk of a concussion based on our experience from other literature. And then it takes that, higher impact and gives it a higher decimal value, maybe a 0.8 or something. And we add it all together and give them the risk of concussion throughout the season. So it's just a way of quantifying, giving a single number to the head impact exposure, taking into account not only the number of head impacts, but the severity of those head impacts. And so in this study, we had 72 football players, and this is the youth specifically, so the middle school. And then we had 17 controls. And we did pre minus post season. So here we did this is for DKI and MEG. This is just an example of that processing pipeline, post minus pre. And then we did a Z-score to the normal controls. And so we calculated the total number of voxels that were active. The reason why we did this instead of doing a voxel to voxel comparison is because the head impacts are so heterogeneous. So if you're hitting the front of your head versus the back of your head, doing that voxel to voxel comparison across is really difficult versus something like Alzheimer's where it always occurs in the same location. So we're taking it and we're saying, okay, give me one number, a scalar number that represents the amount, the volume of abnormality per subject. And so that's what we did here for multiple different metrics, primarily MEG slowing, and then we also looked at FA and mean kurtosis and a couple other diffusion metrics. So we said, okay, if you have more head impact exposure, we're going to have more abnormalities compared to our normal controls. That was our hypothesis going in. And my graduate student, Natalie Bell, who should be defending in November, it's exciting. So she found that more, yes, indeed, more head impact exposure leads to an increase actually in the theta in this age group. So this is the younger age group. And we saw the same thing in the MK. So more head impact exposure means more abnormalities in the mean kurtosis. So other studies have shown delta increased after concussion. These studies were in adults, so I want to point that out. And then previous studies have shown delta decreasing with age during normal development and kind of leveling out around 17 or 18. So if you look here, this is from a normative study where see this sharp decrease in the in the delta power. And this is from EEG. And then look at the scale here. This is the theta, and you see a much lower slope. And so we think we're just, maybe they are increasing in delta, but we're just not sensitive to it because they're at this age, this maturation age of middle school, where their delta is just kind of all over the place and we're not super sensitive to it yet. But so we're seeing that increase in theta. And this is, again, in the absence of clinical symptoms. These kids are totally normal. They're performing well in school. Their neuropsych scores from pre to post season actually improved. So this is totally without clinical symptoms, which is really interesting. Oh, and here's the slide that I lost earlier. So there we go, found it. So we're doing this study of concussion where we're recruiting 40 sports-related concussion participants, 20 male, 20 female, and then contact sport control athletes. We have a really interesting paper coming out soon of our first one was actually a twin. So we had an identical twin that had a concussion in soccer. Her sister did not have a concussion. So we're able to get all of these metrics. So we have blood biomarkers, MRI, EEG, MEG, neuropsych testing, all of this on these two twins. We're really excited about that. So that should be coming out by the end of the year with Natalie's certification. So if you guys know of anybody that we're still recruiting for this study and we're still studying it and we're trying to figure out, get a little bit more information about this concussion. So we still have plenty of time. Now let's go into the Alzheimer's versus CTE. So I've talked a lot about CTE, I've talked a lot about a concussion, and if we go kind of to the end of this concern spectrum to the CTE, we know that the football players that have been diagnosed with CTE have the neurofibular tangles, the tau, they have the beta amyloid plaques, they have the cortical atrophy. So kind of they're checking all of these boxes for a neurodegenerative disorder like Alzheimer's. The difference is in their in the spatial distribution of these changes. So on the left, you'll see the CTE distribution, and on the right, you'll see the Alzheimer's distribution. And this is really interesting to me too, because where you see the greatest number of head impact exposure, or where spatially you would expect to see head impact exposure affecting the brain the most, is in that frontal lobe. And so, and even just kind of thinking about football and the older style of leading with your head for those tackling, that's what we're going to see. And so actually, MEG has been used in Alzheimer's disease for quite a few years now. And we've seen that this similar shift. So the alpha band that reduces, so the black is the controls, the red is the patients, the Alzheimer's patients. And so you see the delta and theta increase in the people with Alzheimer's. And then you see that alpha also decrease, which is not something that we've been able to replicate in the concussion participants. So this is something about the aging process or something about the later onset of the pathology where that alpha peak comes down. And so we see that increase in the delta and theta, decrease in the alpha and beta. This is correlated with cognitive function. So this is one of our colleagues, Alex Weissman. He looked at, and this is a lot to take in, but the MoCA scores versus the delta and theta, and saw that as the MoCA scores decreased, the delta and theta increased, and it's spatially correlated in the temporal lobes, which is where we would expect to see kind of a memory type occurrence. So, and then this is another really exciting body of work from UCSF. It's Kamalini Ranasinghe, who does this work where she sees this hyperexcitability occurring in people with tau pathology. And so they see an increase in the epileptiform discharges in people with Alzheimer's. And then they also see this, it's a decrease in the alpha connectivity and then an increase in the delta connectivity. And it actually, so I've tried really hard to get her to send me a picture, but they haven't been published yet. So the MEG data of this hypoconnectivity correlates really, really nicely with the PET. So she can almost replicate a PET scan with the MEG metrics and show this spatial distribution of changes that we expect to correlate with the pathology. And so they've shown that in mouse models really nicely, where the increased tau, when they do an intracranial electrode, they show the increased delta in those mouse models. And so we tried to replicate this here, and we're working on a study right now where so these are 3 individual subjects from our study. The first one is a subjective cognitive, first one is subjective cognitive complaint, MCI possible. So their MoCA score was 21, but they were pretty well functioning, not clinically diagnosed with MCI. But we see delta power. So this is just delta power. This isn't any sort of fancy connectivity analysis. We see delta power increasing in the deeper structures. And then we move on to the MCI probable, a person who actually did end up eventually being diagnosed with MCI. And we see the spread of that delta power eerily matching what we would expect to see for a tau deposition in this type of population. And then we go to a person with formally diagnosed and CSF confirmed Alzheimer's, and we see that delta power is just really bloomed out and is almost everywhere in the brain. And so this is been able to replicate this now with 5 other subjects along the same continuum, and we're still recruiting for this study and trying to see, and we should do our first PET scan in about 2 weeks. So we have a MEG that we collected on Friday, and then we're going to collect a PET, amyloid PET, hopefully a tau PET if I can scrounge up the money to do it. But so we're going to do the amyloid PET and compare it to the MEG signatures. The beauty of this, or what we're thinking the beauty of this will be, is that MEG is totally passive. It is silent. It doesn't even mess up your hair. You can just run in. It's a 5-minute scan, probably door to door about 20 minutes. So if you're going in for a screening, say you were thinking about long-term detection of Alzheimer's or ADRD, the MEG scan would be something you could get on your way to work. As you're, you turn 50, you start getting your colonoscopy, you go for your MEG scan. And so if we can replicate the PET findings, maybe we can use it as a screener, as a more passive and cheaper screener than the PET. And if it flags, we send them on for further imaging. And so they're actually doing this in Amsterdam. So they have 366 patients so far that they've screened using MEG at their Alzheimer's center. They are actively using MEG as part of their clinical diagnosis and prognosis and treatment plan. So they have Alzheimer's versus subjective cognitive decline, and their accuracy is around 85%, being able just from the MEG. So this isn't even considering all the other clinical pieces. And it's a combination of relative theta and delta power. And then they're also looking at if we have interictal discharges, being able to, there's a different treatment pathway that they're putting them on if they see those interictal and that hyperexcitability than if they just see the delta slowing. So it's a different, slightly different pathology, and they're doing different prognosis and treatment pathways for that, which is just, I think, really cutting edge and really cool that they're pushing that forward. So we are recruiting. If you know of anybody that wants to come in and get their brain scanned, we're doing MOCAs, MEGs, MRIs, and PETs. And then we have an RF1 with Houston where we're doing about a 1 hour resting state. And we're using that to actually look at if we can detect interictal activity. So epileptic-like activity in these Alzheimer's patients. It's something that has been published on a couple of times now in literature. And so we're trying to see if we can get more information on that. So send us your patients if you have any. We won't interfere with any of their other treatment. It's completely passive. So if you have anybody that you think would be interested, or if you know of any refers, please let us know. And then, so in summary, concussions are, as well as the repetitive head impact exposure in adolescent athletes, are linked with neurodegenerative disorders. Oh man. And but this is really poorly understood. We don't know a lot about this yet. So we're trying to use MEG and other tools to better understand this relationship. MEG can see the concussion where other imaging modalities can't. And then lastly, there's this relationship between the CTE pathology and the Alzheimer's pathology that also they share these MEG features. So we're hoping that we can use both of these groups to inform information about the other. And then hopefully in the future, maybe we could use MEG to screen for Alzheimer's disease and related dementias. And this is a teaser. We're working on making MEG cheaper. We have a new system coming in October 15th that will be more mobile. So instead of the kind of scarier helmet looking device, we have this bicycle helmet that they can wear. And so for kids with autism, that is one of our collaborators is really interested in using this for autistic kids. So they wear it like a helmet. They can move around a lot more freely. You can do at Nebraska, they're actually doing these hyper scanning where they're having like mother-child interactions and things like that. So ours is a little bit smaller. It's about 5 by 5, but this is about the 1/6 of the cost of a regular MEG scanner. So if we're pushing this towards prognosis for ADRD or even for prognosis for concussion and things like that, the way we designed it to retrofit a clinic exam room. So this just pops in to the clinic exam room, and you can then have like point of care MEG and scanning that is source localizable. So, all right, and that's it.
What's the relationship between CTE and Alzheimer's in terms of like age of onset and like time course of the?
It really varies, and it's like a newer one, and so it tends to be earlier. CTE tends to be an onset earlier, and we're not sure, is that because of age of first exposure to head impacts, or we're not really sure yet, but in general it tends to be a little bit earlier.
And the time course of the disease?
Oh, that's a good question. I don't know actually off the top of my head. I know that there's a lot of variability in CTE, especially with the severity.
Just a quick observation and then a question. So years ago, I was collaborating with clinicians in Glasgow Coma Scale.
Yeah.
And just to reiterate about the difference between amateur and professional sports. So they were looking at boxing. And everyone knows about punch-drunk syndrome in professional boxers. But no one seemed to be paying very much attention to amateur boxers. Amateur boxers, again, they only do 3 rounds, but they do dozens of fights. So they had young men in Glasgow who were very, very keen amateur boxers. They would be fighting 2 or 3 bouts an evening, 3 rounds each, and they had, literally hundreds of blows to the head. And even, these very fit young men in their early 20s had choice reaction times that were massively slower than control groups. And again, it's scaled with the number of bouts that they had. It's just the same story that you're telling about the amateur versus professional football.
And this is a good point too. So reaction time was one of the only things that we saw it wasn't statistically significant in our concussion population, but we did see a slight reduction in reaction time.
Seems quite sensitive. My question is the species of tau that accumulates in CTE the same species as in Alzheimer's?
I wish I knew the answer to that, and I don't. It's definitely not my area of expertise, pathology. But I don't even want to guess.
Okay, so I think it may be a little bit different. I think the tau that accumulates from brain injury may be different than the tau that spreads spontaneously in Alzheimer's.
That would make sense. And I think there's also a question too over like those participants with Alzheimer's, especially looking back now, did they actually have a clinical concussion that just wasn't ever diagnosed? Because we have to, for our Alzheimer's study, we're very carefully screening for that. And we've adopted a questionnaire that isn't just, have you ever had a concussion, but it goes through this series of questions about like, have you ever had your bell rung? Did you ever hit your head and then feel dizzy? Like this type of thing, because a lot of people won't, especially in the older population, won't endorse that they had a concussion. Not because they're not willing to admit it, just because it doesn't occur.
Great talk, thanks. I wonder what do you think is specific about delta theta power reduction, right?
It's an increase in the delta. Yes.
So what is it? What does it signify? Maybe a little bit about either on the neurobiological that what manifests it, and then what does it signify in relation to cognition?
So we know from pathology studies that stroke will cause delta, kind of any sort of massive brain injury causes this slowing of the brain waves. And I honestly think that there's not enough understood to say for sure exactly what the like neurometabolic changes there, but there's some of the literature is saying, okay, this is actually a healing mechanism. It's as part of the lymphatic signals, this slowing and this cleaning out of the metabolites. And then some of it is just, you don't have the neurons are damaged. They're not firing. They're just kind of like randomly sparking this disorganized. And so it's causing that slower power. I don't know that I have a favorite between the two of those. And then in terms of cognition, we know from epilepsy, from other clinical things that just in general, slowing is bad. You don't want it. You want that alpha, that organized neural oscillation in that alpha or higher.
But it's a matter of power, right? The power reduces. It's not that the frequency slows down.
So it's a little bit of both. So we actually get the reduction of the alpha and the increase in the delta theta power. So it's like it's these neurons are shifting from being in this organized alpha power, this nice, pretty oscillation, and they're shifting to firing at the slower, less organized baby rhythm. So it's, and then I didn't get into it today, but we can get into like there's connectivity in the different bands, there's kind of cross frequency.
Yeah, that was the last bit of my question. Like, how much of it is it localized, and how much is it about coordinating across the brain? Then some of the analysis were like global versus localized.
Yeah, and so in the concussion, at least I can say that we see local focal slowing correlated with what we think would be the area of injury. In terms of Alzheimer's, it's I think there's more of a network, and the hyperexcitability of the network is more at play there.
So you did mention that in the players' concussion study, you were doing blood biomarkers. Is that also going to be the case for the Alzheimer's study?
Yeah, we're collecting blood and serum biomarkers for the Alzheimer's as well. And we haven't decided on the biomarkers yet. This is definitely, so I'm a computer engineer, biomedical engineer by training. And so I'm learning as much as I can, as fast as I can about these blood biomarkers. But I know like NFL will be one of them that we do. And then my graduate student is looking into different markers that we can do for the concussion kids.
Question. I'm wondering how the treatment for brain injury from concussion work. Like the brain regions that are impacted by concussion seem to be very different depending on people. So it looks like it would be very tailored each individual.
Yeah, it's right, and that's part of the problem right now is that they can really only treat the symptoms. So if you're a lot of times, well, and it's hard too because these kids get a concussion. They've gone from doing 2-a-days, with their teams, exercising daily. They're part of this like vibrant community to being then having to sit out. And so we often see depression as part of, and so they'll get a lot of SSRIs is what we've seen the most of in this concussion population for treatment. But other treatments tend to be related to the symptoms and they tend to be more therapies than pharmaceutical interventions. So it'll be things like sleep hygiene. It's a little bit softer than truly, yeah.
So for the helmets that you were talking about, I'm sure there's no way to actually make helmets overall safer and completely mitigate impact. But from what we are seeing in the NFL currently versus what the data is showing, do you think there is a way to help lessen the impact in the NFL right now?
So there is definitely, from a biomechanics perspective, you can reduce the amount of acceleration experienced by the brain by increasing padding. The mushroom caps that they've started wearing, they started doing those back in 2008, I want to say. They did them at Clemson, and a kid actually had a C-spine injury from it because they were used to having the smoothness of their helmet, and now they have this pad and this fabric on the outside, and it was catching on things and twisting their necks. And so they've been working on that for like a decade now, and they finally like re-released them. And so I'm really curious to see if we see an increase in the C-spine injuries now that they've like added more padding to the head. But and then there's a lot. Sorry, there's a lot here. There's also like rugby. If you take away the helmet, does it help? And there's arguments against that as well. But yes, from a biomechanics perspective, you can reduce the amount of acceleration experienced by the brain. You're never going to completely take it away, though. The best way to avoid it is to not hit your head. But yes, but there's so many nuances there too, where you have to consider the whiplash, you have to consider the blast. So there's a lot to it.
So yeah, I was told when I was visiting Australia, I spent some time with the Australian rules football people who were also very concerned about concussion. They're saying, you can get a concussion and a traumatic brain injury with no impact to the head at all, just from twisting or acceleration. And the helmets, because they add to the inertia of the head, can actually be harmful under those circumstances. They have more force, the twisting, the acceleration, the rotation of acceleration. So they saw helmets as being like something of a double-edged sword, particularly in the way the game is, that particular version of hitting your head against other people. So they were less enamored by the idea of using helmets to try to protect their bodies.
And
for a variety of reasons, but that was one of them. And I think rugby has the same argument as well.
Yeah. And so we've seen American football do that a little bit too. So for example, at Brown University, I know, I think they were the first ones to do it, where they don't practice with helmets. They use them in games and in less controlled situations or scrimmages, but when they're teaching the drills, when they're learning them, they don't use the helmets so that people learn. You kind of get the best of both worlds, but then they want to wear the helmets when they're in the scrimmages or in the games in less controlled environments, because then it's still better to have a concussion, or I guess depends on who you ask, but I would rather have a concussion than a skull fracture. So, if you're having to pick between the two, yeah. So, but it's definitely, there's so many nuances there, and people say, oh, well, you just shouldn't wear helmets. It'll fix all of the problems. It's not. There's so much to it. There's so much to the biomechanics there, like you said.
Are there any questions from the remote audience, Camilla?
Yes, we have several questions. So the first question says, how does EMG integrate EEG wave frequency ranges for CTE?
Good question. So I can make sure I understand that. How does the EMG? The EMG is the muscle. Can you repeat it for me? Sorry.
How does MEG
Oh, MEG.
integrate EEG wave frequency ranges for CTE?
Okay, great. Sorry. I thought I misunderstood. Okay, so the MEG and EEG can be collected simultaneously, and they complement each other. And so honestly, we're trying to see with this study where we're doing, the MEG is better at source localization. It's much more expensive. It's a little bit harder to acquire. EEG is going to give you, you're measuring the same neuronal signal. It's just harder to source localize. So maybe, when we are looking into this when we're doing both EEG and MEG, we find out that we don't even need the MEG. We can just do EEG. So yeah, they're very similar. They're very correlated. So if we don't need the specific source localization, then we don't really need the MEG. So that's what we're trying to figure out, is if we need that source localization.
Gamma viable in MEG.
So that is one of the things. So technically, high gamma is better for MEG. So we don't have to worry about the impedances as much. So we are able to get more of the high frequency oscillation.
Closer to the population fire.
Yeah. That's a good point.
Okay,
Yeah.
the next question, it's a little long, so bear with me. It says, I was just reading about football helmet padding, that while they prevent against skull fractures, they do not prevent concussion because they cannot stop the neck movement, whiplash, that causes concussion. Can you help me understand how those different type of injuries relate to your data? I'm wondering about the repeated head impacts you mentioned with no concussion symptoms. Is that what this new safety gear is really preventing instead of concussion? And if so, how much of a safety improvement is that in your view?
Okay, so if we're improving the padding in the helmets, really there's three different types of concussion, or kind of causes of concussion. It's the direct impact, the whiplash, the blast injury. So the only thing that we're preventing with the padding is that direct impact, not necessarily the whiplash or the blast injury. So yes, so in terms of our research, the acceleration was measured at the head level. So even if they had a whiplash, we were recording that. But you're right in the sense that the padding and your point earlier about increasing the weight on the head is going to increase the whiplash. So it's a very complex relationship. I don't know if that answered the question 100%, but
It's a pretty good answer.
okay.
Okay, the next question asks, what therapy can reverse CTE and or AD?
Oh, that's a that's a hot topic. There are some anti-amyloid drugs out there that are, of course, controversial. As of right now, I don't know anything that can reverse it. There's nothing. There's things that have been shown to slow some of the cognitive progression, but nothing that I know of can treat it, especially not reverse it.
And the last question, now age 75 and cognitively normal. I had a 2-week coma and 2 months amnesia in 1970. Would I be a good control for your studies?
Sure, yes, please email us. Wait, let me get back to that. You're speaking my language. Say you're gonna say, yes. So, please message us if you're interested in volunteering. We would love to see you. Sophia is our best person to.
Okay, thank you to Dr. Davenport for amazing talk.
Those are all the questions I have online.
Yeah, thank you.
Yeah, exactly. I got one thing. I'm glad you were keeping it. They make it out of the light. Yeah. I'm. Yeah. Here's my shameless. Hello.
Very good.
Yeah.
Great to see you. See you again soon.
Yes, yeah, great, thank you. I'm glad you liked it. Thank you. It's okay. I'm gonna.
Like there are so many